Hey, everybody. We are coming back to answer some questions from our epic presentation of a while ago now, it feels like. So we apologize for the delay, but we got some great questions and wanted to spend some time talking through them. I'll introduce myself again. My name is Laura Whitman. I'm an LPC, and I am the clinical supervisor at Center for Families Nourish program. And my colleague here.
My name is Natalie Loschiavo. I am a registered dietitian and work in outpatient for specifically working with individuals with eating disorders. And as just a little refresher, Laura and I spoke to how we use an integrative care model in our work with adolescents, specifically in regards to mental health and nutrition. And of course, that overlap happens often in the world of eating disorders. So yeah, we'll get started with some of your questions.
Go for it.
You want to start it out?
Sure. So we had some questions regarding socioeconomic effects of being able to have access to food, malnourishment, and these are such important things to recognize, like we've talked about when we're talking about mental health in general. We're having a lot of overlap with all the different isms and struggles that we see in our society as a whole, and obviously financial realities of people and access to things is a big piece of that. So we really want to be mindful that if, as a provider, as a clinician, for example, if we have to start with helping our clients access those resources, that's the work we're doing before we can even talk about, what it means and what we need to do beyond that. We have to help them find those resources. So as social workers, I know many of you are studying to be. That's a huge part of what we will do on a daily basis is find the resources. Nutritionally, I think very similarly, correct?
Yeah, absolutely. Yeah. So the question was for folks who are malnourished, not necessarily with eating disorders, but malnourished potentially due to socioeconomic circumstances and lifestyle. How do we work with these kids, or any suggestions on working with these kiddos? And yeah, so as Laura mentioned, it's really starting from a very basic level of helping them gain access. So for a dietitian, that might be figuring out where the closest food bank is and what steps need to be taken to access that food bank and those resources. And,
about, lunch, available meals and things like that, reaching out to the school counselors, making sure those kids are on those resources lists as well, things like that.
Yep, absolutely.
So another question we had was around mental health and diet and how those two interact. Obviously a really broad subject, and there's a lot to go over there. In our presentation, Natalie did a really nice job of talking about how malnourishment or a lack of nutrition really affects mood. But when we're talking about some specific things, we saw that somebody asked a question around autism, and what I want to highlight there is we really are seeing a strong connection with autism and disordered eating, and sometimes obviously eating disorders. ARFID, avoidant intake restrictive food disorder, is on the rise, mostly because we're seeing it now. We recognize it now. We understand what we're looking for. So when we have somebody who is diagnosed with autism, that's something we're paying attention to. The big thing to keep in mind is whether the child is autistic, not autistic, whomever the person is, as long as how somebody is nourishing themselves is not, impacting their functioning and their growth and their development, it may not be an issue more than there's certain things they like, there's certain things they don't. It's when it really affects their physical health that we really need to start to address it, because when the physical health is impacted, that's where we'll see the mental health impacted. But there's also a lot of stress that can get created that can impact mental health around families worrying, a lot of parents stress around that can lead to conflict. So it's kind of the effect of sometimes that is going to be a part of the mental health piece. Less maybe the issue itself if it's not causing direct harm. I don't know if you want to speak to that anymore.
Yeah, no, absolutely. I think that's everything that you said is very true. And I think the focus being more so on the impact their eating or their way of eating the impact of it versus are they eating in a typical way? The kind of atypical way that they're eating. Is it causing any nutrition deficiencies? Is it impacting quality of life? Will it impact quality of life at a later time? Is it putting them at risk? And so for me, a lot of times it's just kind of monitoring to see if there are any risk factors. So the specific question that we had, which is interesting, and Laura and I hadn't really talked about this, so sorry to throw this in there, Laura, but the specific question actually spoke about kind of two examples regarding two girls who are on the spectrum, and one is vegan and one is vegetarian. Vegan and vegetarian diets, or folks who are following a vegan or vegetarian diet, is a risk factor for an eating disorder in and of itself. So we've seen that in lots of research that folks who follow vegan and vegetarian diets are just kind of categorically at higher risk of developing an eating disorder. So it would be something that would be a red flag. It wouldn't mean I intervene immediately, but it would certainly be something that I would consider a thing to kind of monitor and pay attention to. And then especially, it sounds like in this case, like there's kind of like that rigidity around it that we would see with someone who's neurodivergent. So kind of monitoring those things as well to make sure it's not turning into a pathology.
Yeah, I think that's a really good point. I'm glad you said that. A lot of the times we will have people be like, oh, I'm vegetarian, and great. Again, it's not a judgment, but like Natalie said, and like we talked about in the training we did, you want to get more information. How long? Why? What, why is that something you're focused on? Why does that matter for you? Is it ethics based for some people? Is it whatever? And that's wonderful. But it is also something that you'll find that a lot of people will at times, if they are struggling, use as a way to immediately reduce or restrict certain foods, because people will back off. Oh, you're vegetarian or you're vegan. It doesn't mean they always are totally conscious of that either. So it's not like you're going to get them to immediately be like, no, I'm not actually one. And it doesn't always mean they are using it in that way. So you really have to be thoughtful and just engage, talk about it.
Yeah, it's actually really interesting too, because a lot of times it doesn't start with that intention as well. So there's some cool research being done and that looks at this, and there's actually some kind of theories, I think, at this point, but some fairly well-researched theories that some of the nutrient deficiencies that may occur as a result of a vegan or vegetarian diet, especially a strict one or one that's not kind of responsibly followed, that can actually kind of trigger some of the obsessions around food and some of the characteristics that you would see in an eating disorder. So sometimes it's also chicken or egg. The eating disorder or kind of that rigidity around food cause someone to latch on to a vegan or vegetarian diet, or did the vegan or vegetarian diet actually create some nutrition deficiencies that may have caused disordered eating or eating disorder symptoms? So we went on a bit of a tangent there. Laura, this one's a good question for you. From the mental health perspective, are food restrictions and purging considered explicit self-harm behaviors?
So that's a great question. Definitely something that can go both ways. There are a lot of those times where you will see people engaging in restricting as a way to do harm to themselves. It may be a response to a lack of self-worth or value, potentially related to trauma, potentially related to just the way in which they view themselves and they feel as if they don't deserve these things. So in that way, I would absolutely look at it as self-harm. On the other hand, you can talk to clients who may be struggling and they view those coping strategies as powerful tools, as things that make them feel good and help maybe shift their emotional state, or they're struggling in a way that can kind of boost them. I've had clients talk about feeling powerful because they can do something that other people cannot do. And so it really depends on the individual, and you have to kind of really engage with them around how it's working for them. So again, always, what purpose is it serving for this person, and how do I help how do I understand that, and how do I get them to help me understand it, and then how do we together make sense of it for them? Anything to add there? Okay.
No.
I think this is some of Natalie's area, lots to talk about here, but there was a lot of questions around in school settings, sports particularly, and some pressures around, just societal peer pressure. But questions related to, are we working with schools? How do we deal with teens, particularly teens who are maybe in some athletics that really focus on weight? Cutting weight for wrestling was mentioned. In general, there's a lot of talk and specifics around people's bodies in certain sports. I'll let you kind of jump in there first.
Yeah. So the question about athletics, yes, I mean, unfortunately, we're still seeing that, and we're seeing it at young ages. So we're seeing that pressure and that focus on body weight, for, in terms of performance or cutting weight or making weight for sports like wrestling. We're seeing that in, elementary school aged children, not just at, collegiate levels and beyond. So it is certainly a problem. Some athletic departments, it's different in each school and each school system and each athletic system. So it's not across the board. Some are much better than others. And it absolutely is problematic in these growing and developing kiddos. In my personal opinion, it's problematic even in collegiate and professional sports, but they're at least adults. So how we're addressing it, we are definitely speaking to sports teams. The dietitians at my practice and myself included speak to sports teams all the time, and around proper nutrition, etc. We will sometimes do kind of like in-services, if you will, for athletic departments as a whole, coaches, trainers. And then on an individual level, we're talking to individual student athletes and their parents and their coaches. So a lot of times if we have a client who is a patient at Balanced and struggling with nutrition in any way, but certainly with eating disorders, we are oftentimes coordinating with the coaches to make sure that the messaging that they're receiving in their team and from their coaches is consistent with the messaging that we're sending. And if not, figuring out a solution so that the student can be safe. So yeah, we're doing a lot of outreach to the athletics. And honestly, what's really cool is we're getting a lot of requests. So we are doing outreach, but we have a lot of coaches and student athletes that are asking their coaches for us to come and talk. So that's always very hopeful to me, that we're not having to knock down everybody's doors anymore, and that they actually kind of want this information. Now, that being said, we have yet to be invited to a wrestling team, but hopefully soon. So, and then we are talking to schools in general. I just finished giving a handful of lectures to a local private school, which again, we were invited to speak there, and they built it into their curriculum, which is rare, and was an incredible opportunity that we jumped on. So they set aside a handful of classes for myself and a therapist, and we did them separate. The therapist spoke on body image and I spoke on eating disorders. And it was very well received. The students were middle school aged students. Is that right? No, that's not right. They were young high school. It was freshmen, I think. And one of the questions here actually is, do we worry about the copycat effect when we're talking to students around this? And I'm going to let Laura speak a little bit to this. My take on it is that I'm very kind of careful when I'm speaking to students to present this information in a really responsible way. I'm not using specifics. I'm not giving examples of how to engage in behaviors or what kind, there are no specifics. I'm talking very broad. It's more about building awareness and encouraging these students, if they're in any way kind of resonating with what we're talking about and some of the struggles, that they can talk about it, that they can come to me, they can come to their, trusted advisors or counselors or teachers at school, hopefully to their friends, to their parents, and not be afraid to talk about it, and kind of and know that what they're going through is real and valid. So that's a lot more of the conversation that I'm having versus kind of the specific behaviors or, treatment or anything like that. I also always give a disclaimer both to the whoever's facilitating the talk, the teacher, the administrator, whatever, that I think it's really important that if a student is going through something or this feels very close to them and very hard for them to sit through, triggering, if you will, I like for them to be able to step out in a safe way and choose not to be a part of the conversation if it's not helpful for them. So that's something that I've never had pushback on from administration. And in terms of kind of the copycat mentality, there could be a risk of that, of course. But I think that the risk of not having the awareness and not having these discussions in schools kind of outweighs in my mind the potential risk of any kind of copycat behaviors. Yeah. So Laura, I'm curious your input on that
No,
piece.
I so appreciate that. And yeah, you at Balance do an awesome job with, like you're saying, the outreach in general. And the opportunities to speak at schools, I think, are so helpful. A way in which we get to intervene sometimes, which is really cool, is we'll have, because our kids will do academics in program, our teacher, Adam, a couple of times has been working with a student on, like, let's say, a health curriculum, and he goes ahead and reads through it and sees this is probably not the best, because unfortunately a lot of health curriculum really communicates the very basics, and it can be one triggering. It also can be, it can provide information without some context, so kids can really take it and not fully understand it. So he's created with these kids different curriculum to present and give to their school instead. So it becomes a useful and more educational tool for them, which has been a really neat way of seeing them make those adjustments. So would love to get in there on some health curriculum if we had a chance. Regarding the copycat thing, that is a big concern all the time that we get with parents, especially coming into higher levels of care. What are they going to learn? They're going to hear kids who are worse off than them. This is going to make them, have more problems. And the reality is, like Natalie said, of course, if you have kids together and they're talking, somebody's hearing something that they hadn't thought about. Of course, there may be interest, there may be curiosity. The reality is, though, if someone is engaging in something or looking for something, it's because they are struggling in one way or another. And if they're going to latch onto it, it's because they need a coping strategy of some kind. They're going to find that whether it's with a group of kids, online, on TV, anywhere else. Unfortunately, we can't put our kids in bubbles. And so I would rather, as Natalie said, always have conversation, because if we do it in a responsible way, if we create the space to talk about these really uncomfortable, maybe sometimes scary or hard things, the kids are more likely willing to say, okay, like, I don't feel so weird for thinking about this or doing this or wondering about this, and maybe I can talk to somebody about having those questions. Years and years ago, in our field in therapy, people didn't used to talk about suicide because they thought it would cause somebody to create suicide, and we know that is completely the opposite, right? That creates more isolation and distance. And I think it's a very similar, we have to be willing to have hard conversation, because as you said, the benefits far outweigh the costs. So I think that's spoken to very well there. I have a very popular question for you. What is the best way to identify good versus junk foods without creating guilt when we do eat or serve them?
It's funny, I heard this question so differently when you read it to me than when I read it myself and prepared for it.
Interesting.
So I'm gonna I don't know how I'm gonna answer this, but well, I think first it's checking in honestly with ourselves around our definition of good versus junk food. And where that definition comes from, and are there any kind of problems that we can identify with our personal definition of food in general, but defining it as good versus junk or whatever the kind of the labels are. So I'll kind of start there, and I'll try to keep this brief because this is a big question, but in defining food as good food or bad food or good food or junk food, the one thing that I I personally really kind of struggle with is this idea that, yes, we know that there's different nutrition value in different foods. I'm a dietitian. I was trained in this. I'm not going to pretend like, Cheetos are equivalent to, almonds or an apple or something like that. They're not. But kind of going back to the idea of the kind of that socioeconomic piece, the foods that some people may call bad foods or junk foods may be the only foods available to a variety of folks. In fact, I can guarantee you they're the only foods available to a lot of folks. And so if that's how they live, if that's what keeps them alive, the foods that keep them alive, I don't know that we can fairly call them junk food or bad food. That's a much bigger issue, right? And I won't necessarily speak to that today. So I'm not going to say that that's not a problem in and of itself, that that's the only food that they might have available to them. But that's certainly not their fault, right? And so by defining those foods as good food versus junk food could certainly impact a person's opinion of themselves and their way of life, their circumstances. That's really unfair and unfounded. So again, what are we kind of defining and why are we defining it as good versus junk? Most people define it based on, again, nutrition quality. So a lot of times our junk foods are our fast foods or our highly processed foods. Again, I'm aware of that, right? There are foods that are more kind of shelf stable, actually, which is why, and less expensive, which is why I think they are the foods that sustain a lot of people. And so I think that if we are going to think of them that way, and that's okay. I think when we're talking about them, though, it's really important that we're watching the language that we're using around them. I'm not here to change anybody's opinion on whether a food is good or bad or junk or not junk, but rather, I think for this conversation, we're talking about kids mostly, and like serving food to kids or talking about food with kids. And when we look at the research that we have, we do know that labeling foods for adults has a very different outcome and impact than it does when labeling food or restricting food for kids. Adults can handle it better. That doesn't mean that it doesn't affect them. Yeah, it doesn't mean that it doesn't affect them. But I think some of that effect is because maybe it's been labeled since childhood for them. But obviously their brains can think in a more nuanced way, less concrete. And so for kids, what we know is that labeling foods for good versus junk or putting any kind of restrictions or judgments on food really does have a pretty profound impact. And the impact is usually the opposite of the desired effect. They are going to want those foods more, consume those foods more. This is in the research, consume those foods more when they have them available to them, and have a much less healthy relationship with food overall, less variety, et cetera. So in my opinion, I think it's important to kind of talk about food as good, period. Food is good. It's good for different reasons. And serving a variety of food. So I think how we model eating and what we offer to kids has a much greater impact than how we talk about food anyway. So if we can just talk less about food and offer more variety and demonstrate a variety of like what variety looks like in the way that we eat, variety meaning including the good food and the junk food, in a very like on an equal playing field. So serving a nice healthy spread with some cookies and chocolate and other things that you might deem junk food or unhealthy, to really kind of neutralize the food and make it all fair game. Did I miss anything?
No, that was, I'm so impressed with you for staying so good in your speaking to that. As a clinician, I am not as good at staying as even in that, because there's so much clinically that we see impacted by the way in which we talk about and label food. And, you know, as not a dietitian, you know, I can't, as Natalie can do, talk about how the food will break down and like, this is so much, this gives your body this, well, this gives your body this. What I always come back to people is your body can take and use any food you give it. And so one of the things we really talk about is when we label food, we're putting value, usually morality, on it, which is why we hear good, bad, right, wrong kinds of language, all or nothing thinking, which really sets us up to either be successful or fail. And if you think about people's relationships with how they talk about food, how they talk about their bodies, that's usually the language in which we use. And as Natalie did such a nice job of saying, it's not our job, especially when we're talking to parents or we're talking to family systems, to change adults' way of thinking and feeling. That's theirs to have. But like Natalie said, for young kids, there's so much more that can impact them early on in their development that'll really last. And my guess is that if someone struggles with this for themselves, if they think about their food or they think about their bodies as good or bad, or being or cheating or fit, you know, all these languages we use, I would guarantee, like Natalie said, you can probably trace that back to some of your own experiences of watching people in your life or hearing about food being talked about in your own life, because that's really powerful. We have food maps, what we learn about our relationships with food and body from our families of origin, from the people in which we're around. And if we want our kids to have a different experience, whether you think it's okay or not, whatever the case is, if you want your kids to be able to kind of approach food in a more neutral way as this is fuel, you're going to have a variety of options to choose from. I want you to do the best you can to create balance around that and enjoy it. Then you're going to want to be mindful of the languaging and the way in which, like Natalie said, you provide that balance. You give them that opportunity, because the more you restrict and the more you make it kind of like an all or nothing, it becomes that. So those power struggles are really, it always shocks parents when I say, you know, don't die on that hill. Like, yeah, they might choose the thing that you label as junk a lot until they realize they can have it when they want, and then it just becomes a food that is normal and not a big deal for them. And I really ask families to take a lot of time to think for themselves, and we will provide some resources that will really open up your own thinking about it, which I think, if you're interested, is really helpful. And again, ties into so many other things that we don't really think are connected in our society. So we'll share those resources, because I could have a field day talking about this all day. So I'll stop myself now.
I know, me too. It's such a, yeah, it's such a big topic. It's such an important topic. It's such a sensitive topic.
Many layers to it.
It's so, there's so many layers, yeah, and levels to it. So it's
macro, there's individual, yeah.
Yeah, it's a really, really good question. And it is easy to get, you know, when Laura and I see kind of the impact that it can have when there is a lot of talk around good versus bad in families, and when we can see the individual impact that that can have on a kid or an adult later in life, it is hard not to get emotional about it. And I think that the good news is we all also have our own experience with it, so we can also be really empathetic and understanding to people who are kind of parents and families and individuals who are struggling to figure this out. I really respect the parents who ask those questions. You know, I really respect a parent who says, well, how can I teach my kid about good food versus bad food? Mm-hmm. Just asking that question, just recognizing that it's a sensitive thing and a topic that they're not confident in, and therefore they want more information. That's huge. That's amazing. I'm often like really congratulating a parent if they're coming to me and recognizing without me having to point out that they need some guidance in this. So.
And to speak to that and the empathy, I really appreciate bringing that in, because it's the society as well, right? We're all doctored in it. So no one is not getting those messages, whether it's coming from family or coming from the greater, you know, it's like the air we breathe. So it's really hard to not lean into those ways of thinking. And so, you know, it's important to, like you said, recognize those conversations are really helpful to have if we can have them.
Yeah. Yeah, I always have to check myself and remind myself that most parents, a vast majority of parents, are doing these things because, like, speaking this way about food or limiting foods, or because they think it's helping their kid. They believe they're doing what's best by their kid. And so for me as a clinician, I'm constantly trying to remind myself of that, because it's easy for me to think of like they're doing harm, and wanting to like quick fix that and like intervene and shake them. But I have to remind myself they don't see it that way at all. They don't see it that way at all. They think they're really protecting their kid. And I can't blame a parent for doing that, Christ. So
that hurts. Yeah. I'll let you go with the insurance question there.
This was a quick question. Do you find that insurance companies or payers cover a number of integrated care providers, especially those clients who receive medical assistance? No. A quick answer. Unfortunately not. And just when I get hopeful about one thing, there are positive things that have happened recently. I won't go into the details of them, but there are some things that are positive and hopeful. And then there are some things where I'm, kicked in the gut again about insurance coverage for services. So,
yeah,
and especially the Medicare and Medicaid plans.
Yeah, and that's a real reality too when we talk about the distinction between, private insurance versus those plans. In higher levels of care, integrated treatment is much more common. Whether you're talking like, for example, our program where you have psychiatry, you have individual therapy, you have family therapy, you have, a dietitian. Those are all incorporated in as part of the treatment. That's really hard to do at an outpatient level of care, and it's usually a team kind of working together, like an individual therapist connecting and working with another provider they're not working together. If you can get insurance to cover, that's really hard and really challenging. But when we do have those higher levels of care, it's much easier to do, because we have to work with that, because we have more acuity in those cases as well, and that's why they're coming into those programs usually. For those assessments. So in that way, when we're doing in our program here, it's a lot easier to do. One of the questions is, have you ever done sessions together? Yes. In this level of care, it's much more common. As outpatient providers, Natalie and I have done that for years as well, because of the benefits that we've spoken to in our presentation of why we need to work so closely together. And they usually are pretty effective and maybe sometimes hard sessions for our clients, but really useful. And I think at the end of the day, usually feels good in the sense they feel cared for and supported, even if it's in a way they don't necessarily want to in that moment.
Yeah. I love joint sessions. I think that they can be hard to coordinate in outpatient, but they are very informative from a clinical standpoint. And yeah, I think that the clients ultimately, I think they ultimately benefit, and I think they feel really cared for.
Yeah.
So
I agree with that.
In part because I think it's very rare that providers are communicating with one another and providing that kind of integrative care that I think patients crave so much and deserve.
I think from the presentation, Blaze spoke to that a lot, the ways in which they loved it and the ways in which they hated it. And I think that was helpful to hear.
Yeah.
So some questions around tests, blood work for providers, clinicians, dietitians, like what's helpful to explore and look at when you're looking at the potential of eating disorder or possible disordered eating issues. I'll let you kind of jump in on that one.
I'll start it, and then I'd like for you to speak to it as because the question was, one of the specific questions was, I wonder what blood work results we as therapists can look for that can help us identify and explore possible eating disorder issues with clients. So Laura, I don't want your take on this as a therapist, but one thing I can say is that lab work in particular, blood work in particular, doesn't give us much information, at least not your standard CBC and BMP, like your standard labs that a primary like medical provider would order. unfortunately really give us very little information. There are some specialized labs that might give us a little bit more, but it's honestly not something that sometimes I don't even know what to look for. And often in the blood is so adaptive that usually you're not going to see issues in blood work until someone's in really, really bad shape. So in fact, it's very frustrating. Sometimes I'll have clients be sent for labs because of kind of protocol and just to make sure that they're not about to, go into cardiac arrest. And they come back clean, good, no issues, which is great, in that they might not be about to have a cardiac arrest go into cardiac arrest in that moment. But unfortunately for the patient, what that says is I'm fine and there's no problem. And that's definitely not the case. Lab work does not identify malnutrition. Again, there are some specific labs that are usually not drawn on a general panel that can indicate malnutrition. But again, that's kind of outside of the scope, certainly in my opinion, of a therapist to need to kind of look out for, especially if you're not a therapist who specializes in eating disorders. What I think is important that we can pay attention to as therapists, dietitians, any kind of medical provider or care provider there are some clinical data points that I think are important. One is, are there any menstrual disturbances, particularly for folks who would menstruate? Because that can be a indicator of malnutrition, and it can be a big one, again, especially in, a young person who has had a menstrual cycle already, or who is at an age where you would expect that they would have had a menstrual cycle. And growth charts are really helpful. And it's important to know what you're looking for in a growth chart. So I would encourage kind of educating yourself a little bit on, if you're not already educated on what to look for in a growth chart. But that can be a really helpful piece of information that anyone could read and look at and say, this person fell off their growth chart. All of a sudden, what is going on? Because usually that's a sign of malnutrition, or undernutrition, or a problem of some sort. So, but Laura, yeah, I want your thoughts on kind of what you do look for as a therapist. And yeah.
Well, this is where I speak to the importance of the integrative, because I am not a dietitian. I'm not a doctor. I'm not all these things, and I'm not going to pretend to be. We can learn along the way and lean into some of those things, but that's where, if you work with a trusted colleague, you can take that growth chart and say, I think I see this. Is this what you see? Or what does this tell you? You want to have that community of support that can really guide you. If you are working with a client as a clinician, a lot of where I want to do my work is in building the story around what's going on for this client, the context. I want to understand. So I want to ask the questions about, both in the past, kind of into the current, what's changed, what looks different, what was your relationship like with food and body then, what's it like now? Tell me about your family system. I want to hear a lot. One of my favorite questions to kind of get a sense of a family relationship with food, and it's not an all or nothing. Like, it doesn't give you, oh, this is exact, but it's telling if you say, what's a typical, weekday dinner look like in your family? It's not judgmental. It's not to say, you might have some people be like, well, 4 people are out of practice and 2 people are like this. And be like, okay, that tells me a lot. Or you might have the families who say, well, we never eat together, or we all just do our own thing. Again, it's not judgmental, but it's telling you, okay, does that mean the kids getting their meal together? Are they really getting it together? What are they doing? So you really want to gather as much information as you can. What you also want to do as a clinician is, if you start to feel like there's some concerns, like Natalie said, like protocol, you always want to kind of check off medical pieces first. You want to make sure that medically somebody is stable for any reason. And if I have any concerns, sending them to their primary care doctor is a key. And I can develop relationships and get release assigned. So I can say, hey, I have some concerns. I think there might be some disordered eating, or I just am not sure, but I think there's some stuff going on with this kid. Can you medically just kind of check? An EKG is also something, like the blood work, doesn't always tell us, right? And that can work for you or against you sometimes when you're talking with a client. They can see it as like, I'm fine. But the medical doctor becomes a key person in your treatment as well, because it really allows you to kind of say, okay, medically, if this person is saying they're not seeing anything, it doesn't mean nothing's going on, but it gives me information to know like what else is playing here. And so I would say like a lot of being willing to ask questions directly when you're seeing or thinking things might be happening around potential disordered eating. And it might take some time. Like you might ask a kid and they'll be like, nah. And then as you build rapport, you might hear something and circle back to it, and then they start to open up. So holding those things in your back pocket sometimes as well is really key. Or asking families, getting other people's perspectives of things can really help complete a picture for you as a provider.
Yeah. You just reminded me of something, Laura, that we can add. We're going to talk a little bit about, we're going to provide a list of resources for everybody, and don't let me forget. There's something that we use all the time. It's called a lab coat card. We didn't create it. The Alliance for Eating Disorder Awareness, which has a different name now, so I'm really sorry, but they're a wonderful nonprofit organization for eating disorders. They created it, and we just use it all the time. And it's a great resource that as any clinician, you don't have to know anything about eating disorders, but if you have it and you are sending a client or a patient or whomever to their doctor to assess for concerns of an eating disorder, you can just pass that along, and it gives you a list of labs to check and tests to do, and then some information for that clinician as well, which has been very helpful. We've given it to parents, we've given it to providers, we've used it if we're wondering specifically what we should be looking for. So I'll make sure to add that. It's downloadable online too for anybody who wants it. So
it's amazing, yeah, for sure. So this is some questions around like treatment in general. So there was a question, was the step up always inpatient treatment? That's a great question. No, if you are, there's a lot of language in higher levels of care that make no sense unless you're in them. So it's a really valuable question. Typically, when we talk about the different types of treatment somebody have, is outpatient is exactly what we imagine, potentially you're working with an outpatient therapist. You could be meeting with Natalie, you could be meeting with the primary care doctor to get medication, which is a great resource. Sometimes you could be meeting with a psychiatrist or a nurse practitioner to get medication. If we notice that somebody seems to be having a harder time, symptoms are starting to increase, or things are interfering with their functioning, school, work, relationships, obviously medical health, mental health, higher levels of care start with typically what we call intensive outpatient. And that would look like anywhere from, sometimes they can be as much as 5 days a week. A lot of times they're 4, sometimes 3 days a week. They're usually like after work or school for people. And the idea is it's like kind of like an added support, like you're going to your school day, but then you go in, you have a couple groups, you work with an individual therapist. You are going to get that integrative team approach typically, psychiatry, therapy, potentially, depending on the type of program, you might get nutrition support. But it's less intensive, right? But it is a little bit more than outpatient. From there is PHP, which is partial hospitalization, which is what we are here at Nourish. That's like full week of treatment, meaning like instead of going to school, somebody's coming here from 8 a.m. to 3:30 and they're doing academics, but they're doing all of their treatment as well. So again, the full integrative team is working with them. And that's a really important piece as well, because that's indication that somebody is really having those impacts interfere with their functioning if they're at this level of care. They're not able to function in school. They're not medically in a space where they're able to get up and focus throughout the day and things because of potentially the malnourishment or different pieces. Their mental health is too severe. They've had maybe an attempt or struggling with self-harm. There's a lot of things with maybe substances. So this is somebody who's really showing, so to speak, that they're struggling. And then you potentially have what we call residential care, which is different than inpatient. Residential is exactly what it sounds like. It's kind of the PHP model, but all day, and you live there. So they're sleeping there. They're getting further resources throughout the day and night, and they're doing all their meals and they're living there, and they're going to do all the things, family therapy, all those pieces, but it's going to happen with the person staying there. And then inpatient is much more based in kind of crisis-oriented treatment. So inpatient is where somebody would often go if maybe there's been an attempt. There's kind of usually a period of observation. Sometimes somebody can be in an inpatient unit for like a 1 to 2 week. It's usually stabilization based, and it's not really built around as much therapeutically addressing things. It's much more about safety. Unfortunately, that can be really challenging at times for people. There can be environments that are kind of scary and overwhelming. It depends. There's some amazing ones, but like everything, it depends on the person and their experience. So different levels of care. When we talk about stepping somebody up, a lot of times it would be to a residential, like a primary eating disorder residential, or a primary general mental health treatment program. Anything I missed there?
Nope. Nope.
You're good? Okay.
I like this question for you, though. I'm going to let you handle this.
Yes. How do you address refusals, reluctance for treatment when they have had poor experiences in the past? This happens all the time. And on a macro level, I'll speak to the mental health system has a lot of work to do. We just do. And I think it speaks to kind of still how, while it's gotten a lot better, there's just not an awareness or a recognition of the need of why things have to be given more attention, given more research, given more focus. Oftentimes it's a lack of resources that make treatment centers and programs maybe not as effective as they could be. Unfortunately, too, sometimes there's just not enough providers or resources available to people. But how we address any type of reluctance and refusal or resistance is we have to roll with it. If I go into something creating a power struggle, that's what I got. I want to really lean in and understand what that experience was like for somebody. I really want to hear out their fears, their worries. I'm going to do that by, a lot of the clinical skills I have. I'm going to attune to that. I'm going to use motivational interviewing. I'm going to talk about the fact that there may be choices, but they may not be choices somebody likes, right? And so I can have two choices. I just may not like either of them. And that's one that kids oftentimes hate. A lot of that work is going to be with the families as well, really asking them to see the bigger picture. Because again, if we're talking about younger kids, they're not thinking both of this moment and their future. They're very in the now, which is wonderful for them. We know the bigger picture and the fears of that. So with parents really speaking to and asking them to hold the immediate boundary to help their kids current and future. So a lot of the times that's the work we have to do with families, is asking them to see the not just moment, but the bigger piece of things. And it's really hard. And it doesn't always work, right? It may be multiple attempts before we can get somebody willing to go there, but I'm going to keep, every time I have the ability, or every time there's a moment where somebody is really struggling, I really want to hold that up and say, I really think there's value here if we can get, Joey into more support, because I think he's needing it. I think that's what he's telling us. His behaviors are communicating that he's really struggling. He's suffering. I think he needs more. So again, there's going to be a lot of work we do behind the scenes to get somebody there, especially if there's been a poor experience, and not pretending those aren't happening. It's just the reality. But that's where recommendations that, of the relationships we build, the programs we work with a lot, we can really speak to that and try to provide some, relief in that, or at least information that maybe makes it feel a little bit less overwhelming and scary.
I have a question for you.
I'll go for it.
I have a question now. I'm curious your take on, and it may differ, or your opinion may differ from, like, as an outpatient provider versus working in a program and making recommendations for, step ups to higher levels of care. Your thoughts on, like, having to hold the boundary of, I can no longer work with you at this level of care if you don't accept the recommendation for a higher level of care.
I mean, I think that is probably one of the most challenging aspects of being a provider, of being, I should say, an ethical provider, because there's a lot of different directions people can go. People can say, yeah, but some treatment is better than no treatment. And there's truth to that. And also there's truth in, do I enable somebody to stay in a position where I know they're not getting what they need, and it's going to continue to cause them to struggle and maybe even feel worse, like they're failing more, or the family system is getting sicker and sicker, versus helping them get better? And do I step back and think, well, this is better than nothing? So a lot of the times, my hope is, as a provider of any level, I don't ever want to surprise my clients or my families. I'm usually, and my goal is to always be very transparent. If I'm thinking about a need for step up, that's an ongoing conversation. It's not coming out of left field. And a lot of the times it's not a, oh, we're here, we got to do this. It's a, hey, we have this, we're kind of coming to this point where this is possible. And, you know, I think if we're still struggling with this behavior, this thing, and this, probably we're going to need to keep moving forward with that. And I will give it a time frame. And that's a way also to work with motivation. If somebody's like, I don't want to do that, be like, okay, like, so if you don't want to go to res, or if you don't want to go to this higher level of care, the family doesn't want to, say like, okay, let's give it a chance to see if they can do it here. Let's really see if they can use these resources and pull in these tools. And what you'll find a lot of the times is, if as a clinician, as you get more experience, you kind of know if somebody's going to probably be able to do it or not. And it's not like you're trying to set them up for failure, but you're trying to help them see the need that you're seeing, but in a way that I'm not forcing somebody out the door or forcing them. I'm wanting them to kind of come to a place where they're accepting it. So I think you could avoid that a lot if you do a lot of the work during and around the process. But when you get to that point, and, you know, I can say even just recently, I had one. Very rarely will I discharge somebody, especially from a higher level of care, because they're not accepting a recommendation, because it's not something I want to do. But unfortunately, if I believe truly that there is risk or harm being done, and in a situation recently, I had a family who wasn't responding to a child who had a very long history, like decade-long history of passive suicidal ideation. And despite us asking them to monitor them 24/7, and despite working with them to get them into a higher level of care, they were kind of not moving forward. And I had literally conversations every day, like, this has to happen, this has to happen, this has to happen. And more behaviors were coming up that were showing not just ideation, but movement towards action. And I was like, red flags, red flags. And the family, I think, was so chronically fatigued that they could not respond, despite my and our team's concern and response. That we eventually had to get to a point where we did hold that line. I said, you know, if this is not done by this point, like even an assessment, then they can't stay here. And sadly, the family did leave, and sadly, the kid had an attempt within a few days. They were okay, luckily, but that doesn't feel good. But that was also the only way to communicate to the family the level of concern we were feeling. So it's one of the hardest boundaries, I think. And it's never a decision that I'm going to make on my own. It was a full team decision, and it was a multiple level conversation having ongoing with my supervisor, my director, like, these are not one-on-one decisions you make.
Yeah.
So very hard, very hard. Hopefully you can do a lot of work to avoid having to get to those places, but it's not always possible.
Yeah.
Yeah.
No, that's really helpful, and it speaks to a lot of things, but it also speaks to the importance of, as a clinician, you know, having support, because that is such a difficult thing to do. I mean, just these conversations around needing a higher level of care in general, but certainly if you have to hold a boundary, it can be terrifying as a clinician to do that, because you do know what that can sometimes mean. So the importance of, as clinicians, us having support, supervision, therapists. So
really understand where and why we're coming from that place too, to make sure that it is through that clinical lens. It is, you know, not me reacting in any way, but like I said, this is, you don't just come to that place. You have to, that's a build, and many other things along the way are happening. So, but yes, lots of support needed to hold those boundaries. Any advice on when parents ignore the eating issues and refuse maybe eating disorder treatment, or let's say working with you, Natalie, that happens sometimes, those recommendations. If you're talking to a family that's not really seeing the concerns you have, kind of how do you work with that?
That's a tough one. A lot of times we are, and we will provide this, like we said, a lot of times we're giving resources, almost as like, here's some second opinions, in writing. When it comes to eating, and because restriction and restrictive eating is so socially acceptable, it is very, very challenging for some folks to see it as a problem, especially, you know, in this case, talking about parents, it's very difficult to see, for some parents to see it as a problem. And then especially in kids who are not at a low weight, or certainly are at a, you know, higher weight or in a larger body. And so, like I said, a lot of times we will provide resources of varying types, podcasts, books, short articles, whatever we think that might kind of suit the parents, and then provide them with, really we try to understand where they're coming from, what is their kind of what's influencing their belief system, their resistance, and trying to speak to that, whether that's, they have concerns medically and they think that avoiding sugar is a good thing because they have a family history of diabetes, learning about that and really trying to understand that, so that we can be very compassionate about their concerns, but also speak very intelligently and specifically, to, again, with good research, good information to why that information or their rationale is not helping their kid, or is blinding them to some issues.
Yeah.
So
Just kind of led into like the idea of like sometimes clients who don't fit like the typical look or are in populations that people don't automatically think of, like identities as male, LGBT. I think that's exactly it. Sometimes people just they don't even open that lens up when they're looking at or thinking about certain people, whether it's body size or type or anything like that. And I think on a clinical level, like you said, it's so much psychoeducation. It's really getting in and understanding the barriers. Sometimes it's really creating the space for the kid to communicate to the family, ask for if they're in that place. I mean, the kid's voice is always the most powerful, right? Like the kid's voice in the room, if they can really advocate and you as a clinician can help them, you might have to do some emotional coaching with the parents about hearing it. I will also say parent resources. So we do support groups like parent supports.
Oh, yeah.
To have them work with their own therapist, trying to have them potentially do some groups where they can talk about their fears or concerns with other parents. Hopefully in those kind of settings, you get parents who are at different levels and can kind of speak to that. But I think, like you said, a lot of the time it's that, how do I build that rapport? How do I approach this in a compassionate and caring way, thinking that this person is most likely working in what they think is the best interest of their child, and try to help them see the concern and where we're coming from. But it's nuanced.
And for me, at least recently, I used to, again, this was another situation where I would find myself, years ago, getting more emotional, and getting frustrated with the parents, whether I was presenting that way or not. I felt it for sure. And I've had to remind myself that, so often acknowledging that your kid is sick can feel to a parent like a failure. And certainly if the parent hasn't seen it, right? If it's gone kind of unnoticed until a more kind of critical place. And so recognizing that there's oftentimes shame in the room as well. So I'm talking to the parent and I'm talking to their shame as a parent. And that's not always the case, but I do try to kind of assume that that's the case in a lot of conversations, so that I'm not, reinforcing anything that does feel shaming for the parent, or that may sound like blame.
Yeah, you have to be really aware of, again, like the conversation, the tone, the way in which you lean into that is, those are the skills you develop as clinicians that, teach you how to see the person, what their barriers are, and maybe how they need to hear it. And sometimes it takes a number of times, but we do what we can, right? Like an initial pushback or not taking it doesn't mean we don't keep advocating and trying. We have to be willing to be persistent in respectful ways.
Yeah.
Yeah.
A few more that we can kind of actually, I think, sort of breeze through just for the sake of time. But Laura, you just mentioned kind of this question got wrapped into another, but how do you broach the subject with clients who do not fit the typical look of an eating disorder? And where do we refer them? So I'll tackle part one, because that's a little bit actually easier. I think screening tools, which was part of another question, can be really, really helpful. And just using them across the board for all your clients, it's a really easy way of doing it to kind of identify if there are kind of risk factors or anything like that. It's a non-threatening way, especially if it is used across the board with all your clients. So we'll provide some of the tools that are out there and the ones that we use, EDEQ, EDE-Q. There's also a version for adolescents, or the eating attitude test, or EAT, are two fairly simple screening tools that are used often in the eating disorder world, or if screening for that. Where do we refer them? Nourish.
I would love that. I mean, obviously, every individual case is unique, and you have to be willing to look at that. You can always reach out to our Center for Families or Newport's assessment team. And if we are not a good location, we will help find, depending on the person, depending on their experience. Like it can be trickier to find good care and specific for an individual. But again, it's out there. You got to just kind of keep tapping your resources, and we can help do that for sure. What questions should non-dietitian clinicians be asking about food and nutrition? And then a second part of that, I'll hold on. You want to ask all about it. You want to talk about a person's relationship with food, relationship with their body. You want to talk, like we said, about their family dynamics around food and body. You want it to be very normalized, kind of the same way you're talking about screening. You should talk to all your clients about these relationships, especially in adolescence and things. Like, we expect body image. We expect, while someone is going through such a major developmental change, that they're going to have feelings about their body. And we know they're hearing things about body, food, things like that. So bring it in. They're talking about social media. What do they look at? Who do they pay attention to? Who are they following? When they talk about their friends, what are their messaging? What are they hearing? Things like everywhere you can pull it in a lot of different ways, but look for opportunities to do so. And going back to the last question, with everyone, not just with the kids you think may be somebody at risk. Mm-hmm. And then the second question, do you two think that the requirements for a client to be underweight to get diagnosed with anorexia is an issue? Yes, 100%. It's discriminatory because it's based on a lot of the isms, as we go back to. So a whole other training to discuss.
It is an issue. Maybe I'm just optimistic, but I mean, the newest DSM edition, which is how old now, 10 years, did make some necessary changes that were good. So hopefully the next one that rolls out might have some more advancements that are good. But what we know is that anorexia is not, it occurs across the span of bodies and the spectrum of different bodies and weights. So hopefully that changes down the road. The good news is there are diagnoses for these folks. There are eating disorder diagnoses. Anorexia nervosa in particular does still have a weight piece in its diagnosis, but atypical anorexia, which is actually more typical, but it falls under eating disorder, not otherwise, or eating disorder OSFED, other specified feeding and eating disorders is what it is now. Used to be EDNOS. So it is a diagnosis. It is covered by insurance. A treatment provider is addressing it in the same way we would, at least for me, I'm addressing it in the exact same way that I would for someone who has a formal anorexia diagnosis. But the shorter answer to that question is just yes, it's a problem.
We mentioned the tools for screening that we use. We'll include them in our resource list for sure. So for mental health clinicians who don't have the opportunity to work in integrating settings, what books, podcasts, and other resources do you recommend to gain a foundational understanding of both nutrition and how to best support clients in nutritional goals? We'll include a lot of things there. I would also just encourage people, remember, practice within your expertise. I'm never going to be able to be a primary care doctor or nutritionist or anything. Like, create your relationships in your community too, and utilize them, because that is really important. But yeah, there's a lot we can do to build our own knowledge up as well.
Yeah. No, that's a really good point.
Yeah.
Okay. I think that
think we're good.
most of the questions. Hopefully we answered most of your questions. And only an hour, so like not much longer than a bad podcast.
I think
All
we
right.
were. Thank you all.
Thank you, Laura, too.
And
I always
Julie,
like working with you and chatting with you. So,
likewise.
all right. Well, like I said, we'll send resources and we'll make sure that our information is also available to you guys in case you have specific questions and need to reach out. I think I can speak for Laura that we are happy to help however we can. So, okay. Now I have to figure out how to stop recording.